As we get started, we kindly ask that you disable any AI note-taking tools, as they will be manually removed once the session begins. Today's presentation will be available on the Blue Cross North Carolina Providers Risk Adjustment webpage for educational use. If you have questions, feel free to drop them in the Q&A box or email us at the email provided on this screen. We will follow up with responses via email after the webinar. This presentation has been approved by the AAPC for one CEU. To receive your CEU, please ensure that you pre-register, enter your name and email correctly, and attend at least 75% of the event using both audio and visual functions on your device. You must be able to see and hear the presentation. Certificates will be emailed within 2 weeks to the address used during registration. If you have not received your CEU within that time period or from a previous webinar, please contact us at bcbsncradj@bcbsnc.com. This presentation is designed for both physicians and office staff. Please note that the content and responses provided are for educational purposes only and should not be considered official coding or legal advice. All coding decisions should be made on a case-by-case basis, supported by medical necessity and properly documented in the medical record. Before we begin, I want to take a moment to introduce our risk management team and some of our presenters for today. Our team is comprised of nurses and coders that have worked in an array of settings with many years of experience. Today, we have the pleasure of hearing from Tracy Cox and Missy Leggett, and I am your host, Jacqueline Duncan. By the end of today's webinar, you'll be able to better understand common pulmonary conditions and their impact on overall patient health. You'll also gain clarity on how to code these conditions accurately and completely and recognize key opportunities to improve documentation related to pulmonary care. Now I will pass things along to Tracy Cox to discuss respiratory system overview. Take it away, Tracy.
Okay, thank you, Jackie. So we can jump right in. Um, Let me ask, can anyone see the screen? Um, okay, so if you can't see the screen, then maybe log out and come back in. Um, I saw in the chat there was a lot of people that were saying they couldn't see. Okay, Tammy says I had to log out and in. Okay. Okay. All right, so we'll just go ahead and get started. If you can't see, try logging out and back in. And then, of course, like Jackie mentioned, the slides will be available after the presentation. So, all right, so the respiratory system is made up of several interconnected parts that all work together to help us breathe. Its main job is to bring oxygen into your body and remove carbon dioxide. But it does more than just help you to breathe. It also warms and moistens the air, protects you from germs and irritants, helps you talk and smell, and even helps balance the acidity in your body. While the lungs are the primary organs, the system also includes the nose and nasal cavity, mouth and oral cavity, sinuses, pharynx or throat, larynx or voice box, trachea or windpipe, bronchi, and the diaphragm. As air enters the body, it travels through the upper respiratory tract, which includes the nose, mouth, sinuses, pharynx, and larynx, where it is filtered, warmed, and moistened. From there, the air moves into the lower respiratory tract, which consists of the trachea, bronchi, and lungs. Within the lungs, the bronchi branch into smaller tubes called bronchioles, forming what is known as the tracheobronchial tree. These airways carry air to tiny sacs called alveoli, where oxygen is exchanged for carbon dioxide, completing the process of respiration. Fun fact about alveoli: after surgery, anesthesia can cause shallow breathing and reduce lung expansion, which may lead to the partial collapse of the tiny air sacs or alveoli. This collapse, known as atelectasis, limits oxygen absorption and increases the risk of lung infections. Deep breathing exercises, especially those using an incentive spirometer, help to reopen these alveoli, improve oxygenation, and prevent atelectasis by fully inflating the lungs and maintaining healthy airflow. The conditions listed here are commonly seen and each have specific criteria needed to be diagnosed as well as coded. Many can vary in severity and remain managed on minimal treatments for long periods of time. We will be discussing the different types of treatments for each condition and what documentation should be present to support them. Let's get started with respiratory failure. The respiratory system plays a vital role in supplying the body with oxygen and eliminating carbon dioxide. When this gas exchange is disrupted, respiratory failure can occur. There are two primary forms of respiratory failure: hypoxemic or type 1, where oxygen levels are too low, and hypercapnic, type 2, where carbon dioxide levels become excessively high. Respiratory failure can result from lung disorders, damage to the chest, or issues affecting the muscles and nerves involved in breathing. Common symptoms include difficulty breathing, mental confusion, fatigue, and a bluish discoloration of the skin. Treatment is aimed at resolving the root cause and may involve oxygen supplementation, medications, or mechanical ventilation in more critical cases. Respiratory failure can be acute, chronic, or acute on chronic. Acute respiratory failure is a sudden and severe impairment of the respiratory system. This can lead to low oxygen levels and or high CO2 levels in the blood. Acute respiratory failure is a medical emergency and requires immediate care. Causes include things like infection, such as pneumonia, acute asthma exacerbations, or drug overdoses. Onset occurs within minutes to hours, and symptoms may present as shortness of breath, confusion, cyanosis, or rapid heart rate. Treatment will vary depending on the oxygen and CO2 levels, but may include supplemental oxygen, mechanical ventilation, medications, or a combination of these things. Chronic respiratory failure is often caused by a chronic lung disorder such as COPD, scarring and inflammation of lung tissue, as seen in interstitial lung disease, or neuromuscular disorders that weaken the respiratory muscles, such as ALS. Treatment includes managing the chronic lung disorder, the acute symptoms, and improving the lung function of the patient. Acute on chronic respiratory failure is acute deterioration in a patient already suffering from chronic respiratory failure. These episodes are usually caused by an underlying infection or pulmonary embolism. Symptoms include exacerbation of current chronic symptoms and new acute symptoms, such as altered mental status and worsening hypoxemia. Treatment of the cause of the acute event should be prompt, and management of the chronic lung disorder should be considered during treatment. Throughout this presentation, we will explore many of these causal conditions in more detail and explore coding considerations for each. This slide shows the associated ICD-10 codes for each type of respiratory failure, acute, chronic, and acute on chronic. Providers should be encouraged to document the details needed to adequately code and describe these conditions. This includes acute versus acute on chronic status. Is there hypoxia or hypercapnia present? And what treatments are being used? If chronic respiratory failure is documented, they should be queried and asked if there is an underlying lung disorder present. If so, that will need to be included in the documentation and coded on a claim. Now we'll take a look at some acute conditions that can impact lung function. Okay. First off, we'll talk about pneumonia. So pneumonia is an infection that causes inflammation in the air sacs of one or both lungs, often leading them to fill with fluid or pus. It can be caused by viruses, bacteria, or fungi, and individuals with certain underlying health conditions are at a higher risk of developing pneumonia. When coding for pneumonia, it is essential that providers clearly document the causative organism or virus if known. This slide shows code sets that can be used to communicate the causal organism or virus for the pneumonia diagnosis. In cases where the organism is unknown, coders should use the appropriate unspecified codes from J18 to J18.9. And don't forget to scan provider documentation to see if the pneumonia is related to influenza or if it involves a lung abscess. Any additional conditions that impact the risk level of the patient for pneumonia should also be documented and coded on a claim. Examples of this include Parkinson's disease or history of stroke, both of which elevate a patient's risk for aspiration, leading to pneumonia. Finally, coders should capture any relevant clinical context, such as the presence of respiratory failure, trach or mechanical vent status, oxygen use or dependence. All of these should be included in the provider assessment and documentation. Pneumonitis is a general term for inflammation of the lung tissue, often caused by irritants rather than infection. Hypersensitivity pneumonitis occurs when fine dust of natural materials is inhaled and causes an allergic reaction and inflammation of the lungs. Allergy to the substance can take months or years to develop, but damage can be reversed if the allergen is avoided in the early stages of the disease. Once lung scarring and pulmonary fibrosis sets in, the damage is permanent. The most common type of hypersensitivity pneumonitis is farmer's lung, which is caused by exposure to moldy hay, grain, and straw. Other causes include organisms growing in air conditioner ventilation systems, fungus and humidifiers and heating systems, coffee beans, bird droppings, cork, and many other substances. Code set J67 to J67.9 is used for hypersensitivity pneumonitis due to organic dust. Again, examples would be farmer's lung, bird fancier's lung, AC and humidifier lung. The next code set, J68 to J68.9, is used for respiratory conditions due to the inhalation of chemicals, gases, fumes, and vapors. With these, you'll need to code first from code set T51 to T65 to identify the cause, and then you'll also use an additional code to identify any associated respiratory conditions, such as acute respiratory failure. Code set J69 to J69.8 is for pneumonitis due to solids and liquids. Examples of this would be vomit, regurgitated food, inhalation of oils or essences, and aspiration of detergent. Providers should be encouraged to document and link any medications or treatments in place to the condition, document and link the cause of the pneumonitis in the patient's chart. Okay, now we'll take another look at asthma. Asthma is diagnosed based on severity. Severity is categorized based on the degree of impairment and risk of exacerbations requiring oral corticosteroids. Impairment is assessed over the previous 2 to 4 weeks, and then the risk is assessed over the past year. Asthma is classified based on the age of the person, the frequency and severity of symptoms, as well as lung function. The classifications include intermittent, mild persistent, moderate persistent, and severe persistent asthma. Let's take a closer look at the criteria in each severity classification. I'd like to stress that a provider is going to use this as a guide in addition to all of the other things they will learn during a history and physical. These guides are meant to support and not replace the clinical decision making your providers will practice during each visit. Your providers likely use this chart or something similar when assessing these patients. It is important that you help them to understand the differences in symptoms within each code so that reimbursement will be appropriate to take care of the member based on the severity of their condition. When coding asthma, it is important for your providers to include the type of asthma, such as extrinsic, intrinsic, the severity of the condition, such as mild intermittent, mild persistent, etc., the current status of the patient's asthma, if an acute exacerbation, status asthmaticus, or if it is uncomplicated, and then also capture any causal effects, such as exposure to tobacco smoke. All of these details will be used to build your asthma code to accurately reflect the status of the patient. Codes with 6-digit characters indicate unspecified or other asthma should be used as a last resort. Now we will shift from acute conditions to chronic conditions that can impact pulmonary status. Okay, so we'll start with chronic obstructive pulmonary disease or COPD. And this is a group of progressive lung conditions that obstruct airflow and make breathing increasingly difficult. The two primary diseases under the COPD umbrella are emphysema and chronic bronchitis. Both of these contribute to inflammation, scarring, and structural damage in the lungs and airways, ultimately impairing respiratory function. COPD leads to several changes within the lungs. Patients often experience airway inflammation and fibrosis, damage to the alveoli or air sacs, and thick mucus buildup that blocks airflow. The lungs lose elasticity, making it harder to exhale fully, and the destruction of alveolar walls results in enlarged air spaces and air trapping, further reducing gas exchange efficiency. Symptoms of COPD typically worsen over time and include persistent coughing, wheezing, shortness of breath, and increased mucus production. Patients may suffer from exacerbations, sudden flare-ups of symptoms, characterized by severe breathing difficulty, thicker mucus, and intensified coughing and wheezing. These episodes can become more frequent and severe and sometimes require hospitalization, and this will contribute to a gradual decline in lung function. While progression is usually slow, some individuals may deteriorate more rapidly. The structural and functional changes caused by COPD can lead to serious complications. These include pneumonia and bronchiectasis. Excuse me, I know I'm not saying that one right. A condition marked by permanent airway dilation and chronic mucus buildup. These complications further impair lung function and increase the risk of infections and hospitalizations. ICD-10 coding for chronic obstructive pulmonary disease falls under the J44 category, with specific codes assigned based on the presence of complications or coexisting conditions. J44.9 is used when COPD is documented without mention of an acute exacerbation or lower respiratory infection. This is the standard code for uncomplicated cases. When an acute lower respiratory infection is present, J44.0 should be used, provided the documentation clearly supports the infection. Any identified organism should be coded separately, and aspiration pneumonia should not be included under this code. For cases involving an acute exacerbation, J44.1 is appropriate, especially when the provider notes a sudden worsening or describes the condition as decompensated. However, this code should not be used for end-stage COPD or when multiple respiratory conditions coexist. J44.81 is designated for COPD with bronchiolitis obliterans, a severe and irreversible condition often linked to toxic inhalation, infections, or organ stem cell transplants. In such cases, transplant complications should be coded first, followed by additional codes for related conditions like chronic graft versus host disease or exposure to harmful substances. And lastly, J44.89 covers other specified forms of COPD, such as chronic obstructive asthma or bronchitis, particularly when persistent airflow obstruction is present. This code is suitable for patients with overlapping conditions like asthma and COPD, where airflow limitation is continuous rather than episodic. Now I'll pass things over to Missy Leggett to talk about other chronic lung conditions.
Thank you, Tracy. Next up on our chronic conditions list is bronchiectasis. Bronchiectasis is a chronic lung condition characterized by permanent damage, widening, and thickening of the bronchial tubes, the airways that carry air in and out of the lungs. This structural damage impairs the normal clearing of mucus, allowing bacteria and mucus to accumulate. As a result, individuals with bronchiectasis often experience persistent cough, frequent lung infections, and airway blockages. The condition involves the dilation of the bronchi, often accompanied by excess mucus production and chronic cough. It may arise from infections or long-standing inflammatory conditions that reduce lung capacity and increase susceptibility to recurrent respiratory infections, such as chronic obstructive pulmonary disease. Bronchiectasis can develop following any significant lung injury. It is generally characterized it is generally categorized into two main types: cystic fibrosis bronchiectasis. This is a form that is associated with cystic fibrosis, a genetic disorder that leads to the production of thick, sticky mucus affecting the lungs, pancreas, liver, and other organs. The abnormal mucus promotes repeated lung infections, which can result in bronchiectasis. The non-cystic fibrosis bronchiectasis is unrelated to cystic fibrosis and may result from a variety of underlying conditions, including severe respiratory infections such as pneumonia or tuberculosis, allergic bronchopulmonary aspergillosis, primary ciliary dyskinesia, primary or secondary immunodeficiency, COPD, and severe asthma. Bronchiectasis is coded under ICD-10 code J47. The fourth character in the code provides additional specificity. It indicates whether there is an acute lower respiratory infection present. It identifies whether the condition is exacerbated or decompensated. And if neither of these applies, the uncomplicated option should be selected. When applicable, you should also code for the specific infectious organism if known. Next up is emphysema. Emphysema is a condition of the respiratory system that restricts the airflow during exhalation because the bronchioles and the alveoli deteriorate gradually. This causes a loss of lung elasticity, which can result in significant breathing difficulty. As this condition progresses, the spherical air sacs within the lungs become irregular and contain holes, reducing not only the number of air sacs, but also the amount of oxygen that can circulate into the blood from the lungs. As the air sacs deteriorate, the openings collapse, trapping air within the lungs. Treatment for this condition can slow down the deterioration. However, once the damage is done, it cannot be reversed or cured. Smoking and air pollution are main contributors to emphysema. McLeod syndrome is another form of emphysema in which one lung becomes somewhat transparent in conjunction with the reduced oxygen and carbon dioxide exchange within the blood. McLeod syndrome is also known as Sawyer-James syndrome or SJS. Centrilobular emphysema occurs mainly in the central part of the lobule and is the most common form of emphysema. This form occurs most often in the central portion of the upper lobes and is more frequently seen in men than women. Smoking and dust inhalation are the primary risk factors associated with this type of emphysema. Now let's discuss interstitial pulmonary disease. The interstitium is the network of tissue that contains thin layers of cells and blood vessels that surround and support the air sacs. When this tissue is damaged, it causes scar tissue and results in breathing problems. Conditions related to this are bundled under interstitial pulmonary disease. There are 5 broad categories of interstitial lung diseases based on the cause or the triggering condition. Detailed and clear provider documentation is critical to support the coding of these conditions. Interstitial lung disease refers to a group of chronic lung conditions that cause inflammation and scarring between the air sacs, leading to breathing difficulties. These, these diseases often result from environmental, occupational, or autoimmune factors. Symptoms of ILD include shortness of breath, cough, fatigue, and chest discomfort that begins as mild but worsens over months or years. A detailed health history, including prior exposures to dust, chemicals, or other irritants, is essential for accurate diagnosis. Identifying the cause helps determine the specific ILD type and guides treatment. Any known exposure should be clearly documented and coded in the claim, especially if it has led to related conditions like silicosis, which is caused by prolonged inhalation of silica dusts, which are found in certain types of stone, rock, sand, and clay. Proper coding supports both clinical care and compensation processes. Sarcoidosis is thought to be due to an exaggerated inflammatory response to certain antigen triggers in a genetically susceptible person. Normally, the immune system sends cells to fight harmful substances, causing temporary inflammation. Once the threat is gone, the cells and the inflammation disappear. In sarcoidosis, the immune response doesn't shut off properly. Instead, the immune cells cluster and form granulomas or small areas of inflammation. Potential triggers should be explored and documented by the provider. Any environmental or occupational exposures, such as mold, mildew, or pesticides, should be well documented and coded on the claim. Sarcoidosis often affects the lungs and the lymph nodes, but can impact any organ. Documentation and codes submitted on the claim should reflect the specific organ affected. If the specific organ is not linked with the condition, you should query your provider for clarification. A code from the D86 category should be used to code sarcoidosis along with the appropriate Z code to communicate environmental and/or occupational exposure. Pulmonary fibrosis is a lung disease where the tissue in the lungs becomes scarred, stiff, and thick, making it difficult to breathe and for the lungs to get enough oxygen to the blood. Symptoms include shortness of breath, a persistent dry cough, fatigue, and clubbing of the fingers or toes. Causes can include environmental and occupational exposures, certain medications, connective tissue diseases, and genetics, but often the cause is unknown, which is idiopathic pulmonary fibrosis. While there is no cure, treatments aim to slow the scarring, manage the symptoms with medications, oxygen therapy, or pulmonary rehabilitation, and in some cases, a lung transplant may be considered. When coding pulmonary fibrosis, it is important to confirm that the provider has clearly documented the diagnosis in the medical record. As a coder, we cannot pull this diagnosis from an X-ray or CT result. It has to be given as a diagnosis from the provider. Check to see if there are any additional treatments in place that should be coded, such as oxygen use or a history of a lung transplant. Exposure history should also be documented in the medical record, like many other pulmonary conditions discussed today, along with the corresponding Z code. The oxygen use, history of a lung transplant, and/or any exposures should be documented and coded on a claim at least once annually. Now let's look at some other common lung conditions. Bronchitis is a condition where the large airways in the lungs become inflamed. It often appears as an acute illness, typically during respiratory infections. However, chronic bronchitis is different. It is a long-term condition and a form of chronic obstructive pulmonary disease, or COPD. Chronic bronchitis is marked as by a persistent productive cough caused by ongoing inflammation and excessive mucus production in the bronchial tubes. The most common cause is prolonged exposure to irritants, especially cigarette smoke. Treatment focuses on relieving symptoms, avoiding further exposure to irritants, and slowing the progression of the disease. Within the coding for chronic bronchitis, you will have a couple of options to communicate further details about the sputum involved with the patient. Mucopurulent, simple, and mixed. Mucopurulent bronchitis is persistent, purulent, and recurrent. Simple and mucopurulent types of bronchitis can occur together, and this condition is classified as mixed chronic bronchitis. Providers will need to document the associated symptoms clearly to support their diagnosis. The other option is J42 for unspecified chronic bronchitis. When coding chronic bronchitis, it's crucial that your provider document the chronicity in the medical record. Again, as coders, we cannot assume that chronic, based on the length of time the patient has had the condition. It has to be documented and diagnosed by the provider. All medications, including oxygen use, should be linked, and the frequency and last time of use should be noted for any that are in need, that are as needed or PRN. Finally, no matter which code you choose, you will need to use an additional code or codes to identify any risk or causal factors for the condition, such as tobacco use, occupational exposures, and tobacco exposure. Lung cancer is the leading cause of cancer deaths among men and women in the United States, with nearly 200,000 newly diagnosed cases and more than 130,000 deaths annually. Risk factors include smoking, asbestos exposure, radon gas, radiation exposure, genetic disposition, lung diseases such as COPD, and air pollution. Lung cancer is classified according to the bronchus or lobe and laterality. There are three main types of lung cancer: non-small cell, small cell, and lung carcinoid tumor. Non-small cell is the most common, and it includes squamous cell, adenocarcinoma, and large cell carcinoma. Small cell is also referred to as oat cell cancer. Lung carcinoid tumor, also referred to as neuroendocrine tumor, is the least common and is not included in this category. When coding lung cancer, it's essential that the provider documents the specific type and the specific location within the lung, such as the middle lobe, upper lobe, overlapping sites, or main bronchus. Knowing the exact location enhances coding precision and helps in identifying any new lesions or cancer sites more easily. Once the location is documented, it's important to determine whether the cancer is primary or secondary, malignant or benign, and whether its behavior is uncertain or unspecified. These details are all critical for accurately building the cancer code. After establishing the characteristics of the cancer, the next step is to review the provider's documentation to determine whether the cancer is active or part of the patient's history. Active cancer refers to cases where the patient is currently receiving treatment, including adjuvant therapies. It also applies when a patient has refused treatment, as the cancer is still considered active. On the other hand, a history of cancer means that the patient is no longer receiving treatment, and though no treatment is active, this information remains important for ongoing care planning. All treatments and cancer status should be clearly documented by the provider, and the onset and resolution dates should be included in the problem list to ensure comprehensive and accurate coding. When a history of cancer is present, Remember to include Z85.9 on your claim submissions at least annually. Moving along, let's talk about coding for the management of chronic pulmonary conditions. Lung transplants are seen frequently as a treatment for many of the conditions we've talked about today, and these include COPD, pulmonary fibrosis, and sarcoidosis, just to name a few. Lung transplants can be single or double and are done on people of almost all ages. Post-transplant concerns include infection, blood clots, blockage of the airways, and lung rejection. Providers should document the date the transplant occurred, the location, the type of transplant, and link any pertinent ongoing medications. History of lung transplant should be coded at least annually and as often as it is considered during a patient visit. Z94.2 is the code used to communicate this. A tracheostomy is a surgically created opening into the patient's windpipe or trachea to place a tube to allow oxygen to be delivered to the lungs. Trachs are needed for a variety of reasons, including obstruction to upper airway, chronic lung diseases, or as an alternative to long-term endotracheal intubation. Many patients live at home with a tracheostomy for various reasons. When these patients are seen in the office, Z93.0 should be included on their claim and medical record documentation. When a patient is in the office for an adjustment or change out to their trach, you would include Z43.0. If tracheostomy complications are present, you would refer to J95.0 code set to reflect these, including but not limited to tracheal stenosis, hemorrhaging, or infection. Now let's look at some ways to best utilize your EHR or clearinghouses to ensure accurate capture and recapture of chronic conditions. Here are some considerations to help you adjust your workflow and ensure correct diagnosis codes are being captured. Sometimes we hear from providers that more specific codes can be grouped under a less specific or an unspecified code in their EHR, and that providers may be prompted to use that code instead of a more specific code. Make sure the specific code you need isn't grouped under a unspecified code or a generic code that may not reflect the severity of the condition. Also, ensure that there is a chronic option available for providers to choose from and not just acute codes, whether it be in the progress note or an alert or pop-up box. If providers notice a diagnosis code that they need to select isn't available and they feel it should be, encourage them to communicate that, especially with their EHR team. They can help correct the issue. You should always add onset and resolution dates, if applicable, to the conditions on the problem list, letting anyone reviewing the medical record know if the problem is still active. Also, review discharge summaries and any specialist notes for any new conditions that the patient may have to make sure it is addressed properly. Let's go over the key takeaways for today's webinar on risk adjustable pulmonary condition coding. First, remember when coding pulmonary conditions to capture any environmental factors impacting the patient's pulmonary condition. Providers should be encouraged to review, document, and submit these on a claim at least once annually. Also, don't forget to link all medications and their frequency and/or last time used for any PRN medications, including oxygen use. And lastly, details are important. The more specific and detailed the documentation and coding, the better. Now I'm going to toss it back to Jacqueline to conclude our time together today.
Thank you, Missy. Thank you all for joining our educational webinar today. We appreciate your time and we hope you found this session informative. We offer group risk coding training for your practice tailored to your needs, whether you prefer virtual sessions or on site training. Please use the QR code provided to give your feedback on today's presentation. And additionally, if you are interested in group training, scan the QR code to show your interest. I would like to give a big thank you to our speakers, Tracy Cox and Missy Leggett, for their insightful contributions today. And again, I am your host, Jacqueline Duncan. We look forward to seeing you at our next webinar next month on behavioral health risk adjustment coding. For more information about upcoming webinars or group training sessions, please visit our external site using the provided links on this slide. This concludes our webinar. Thank you and have a wonderful day. This slide will be left up for about 9 minutes, so please scan the QR codes for the information that we announced. And we would love your feedback on any topics that you would like to hear in 2026.